Hi, my name is Neri, and I'll be your host for the evening. Thank you and welcome for joining us. Today, you're going to hear from Dr. Thomas Nasser and Dr. Kyle Hopkins from AVORS, who graciously volunteered their time to provide beneficial educational information on the treatments of chronic nerve pain or non-surgical back pain and painful diabetic neuropathy. So firstly, everyone is muted and your video is turned off. This is to protect patient privacy and to limit interruptions so that everyone can have the best experience possible. Secondly, the doctors will be conducting a Q&A session at the conclusion of the presentation. All questions will be taken through Zoom chat. Please locate the chat icon at the bottom of the screen on your Zoom toolbar. You may ask a question at any point during tonight's presentation. Please keep in mind that due to patient privacy restrictions, the doctors will not be able to answer any questions specifically about your medical condition, but are happy to address any questions about the content discussed. So I'm going to turn it over now to Joseph Hurley, who is the CEO of AVORS, to make the introductions. Thank you so much for being here.
Hi there again. My name's Joseph. I'm the Chief Executive Officer of AVORS Medical Group. Happy to be here today and to kind of show off some really good providers we have. The two I'll be talking about is Dr. Thomas Nasser and Dr. Kyle Hopkins. Dr. Nasser, oh, let me get this thing right. There we go. Dr. Nasser, one of our founding fathers of AVORS Medical Group, that stands for Antelope Valley Orthopedic Rehabilitation Specialist, a doctor of osteopathic medicine. As I said, he's board certified physical medicine and rehabilitation. One of the cool things about him is he's the medical director at the Rehabilitation Institute at Palmdale Regional Medical Center. That's a very big medical center and the only acute rehab in the entire Antelope Valley. And he gets many patients all throughout the valley, all throughout LA. I will tell you, he's very personal with his patients, very kind. And also presenting today is Dr. Kyle Hopkins. One of the very interesting and cool things about him is he is the only trauma-trained foot and ankle trauma surgeon in the Antelope Valley. He's the only foot and ankle trauma surgeon who also is on call at all the hospitals, and very strong fracture care, very strong regenerative medicine, works a lot on the diabetic and neuropathy side, and pretty soon is going to be the limb salvage medical director of the Palmdale Regional Medical Center. So very, very fun to talk about him. Broad spectrum care for all of foot and ankle needs, meaning while he's a surgeon, he's also a podiatrist. And what that means is when you come in for nail care, for nail avulsions, for any type of thing related to the foot, he's there to help you. And he's Dr. Thomas Nasser and Dr. Kyle Hopkins are accepting new patients in the Lancaster and Palmdale, and Dr. Kyle Hopkins is accepting new patients in our Santa Clarita and Valencia office. Who is AVORS? I kind of told you our name, but founded in 2005. We have some of the hardest working surgeons in the area. We're a multi-skeletal, multi-specialty clinic, meaning we have trauma, we have total joint, we have hand, elbow, and upper extremity. We have Dr. Thomas Nasser and what he does with pain management and interventional pain management, meaning he tries to do interventions and to not be on medications, but to have interventions like injections, bracing, diet and exercise, a whole slew of different things that he'll be talking about. We're a very busy clinic, but we love our patients. And we have a quote that's AVORS strong, because our goal is how to help our patients be strong and how to get them independently healthy, meaning they don't have to come see us. They can get better and take care of themselves. I'm going to introduce, again, Dr. Kyle Hopkins. He's going to take my chair for a second. Again, he's our trauma foot and ankle specialist, and he'll be talking today about diabetic neuropathy and a few other things. Dr. Hopkins.
Thanks, Joseph. All right. Hey, everybody. Hopefully you're having a great night. As Joseph introduced me, I am Dr. Kyle Hopkins. Pleasure to be talking with all of you tonight. All right, let's get into this. So I would say that it's not a strange thing that the vast majority of my patients have diabetes. In fact, 34, as you can see on the board, 34 million people in the US have diabetes. That's 1 in 10 people. And there are even statistics hinting that 1 in 5 people don't even know that they're diabetic. And it is a very debilitating disease. There's no question regarding that. I have seen, even in my own family, just the amount of this. Oh, thank you. The amount of pain that it can cause, that even a little brush of just a little touch can send people off into pretty significant pain. So it's always good to get checked out right away and stay with those physicals. All right. And then, so you can see with this chart that this right here is the people diagnosed with diabetes. And then 20% of those people develop peripheral neuropathy. And peripheral neuropathy is numbness, tingling to like the feet and hands. I of course see it mostly in the feet because that's where I focus my specialty on, but it's in what's known as a glove and stocking distribution. So people who get it in their hands also get it in their feet and vice versa. Now, the majority of the complaints that I get with that are just like, oh, it's a little bit irritating. It's a little bit tingly, especially at night. Sometimes I get burning sensation, but 20% of the people with they get significant pain with this, where it's just like, hey, I can't sleep. Like, it's really causing issues in my life. I've heard stories where people say that like it feels like they're on fire. It hurts so bad. And unfortunately, with a lot of these, with a lot of people with neuropathy, that conventional medical management, 45% of that, a lot of studies show that the medical management that we typically do just doesn't work. There we go. So the typical treatment that we do for this is, number one, it's not listed here, but sugar control. That is number one, what people need to do. Or else none of this stuff, like the conventional treatments, are going to work. And I'm very upfront with my patients about that. But the medications that we typically do are, some of you might know, gabapentin and Lyrica, which are anticonvulsants, seizure medications even. And then sometimes people don't work, it doesn't work with that. So then we try certain antidepressants, and then we try to stay away from this as much as we can, but sometimes we just need to go for it, is more of the heavy duty pain medications, oxycodone, opiates, tramadol. One of the treatments that I really like to do in the beginning is a topical cream, capsaicin cream. It's actually from chili peppers, but it works pretty well. But there's a big caveat. It actually burns the first couple times you use it. So that turns a lot of people off of it, which understandable. It's like rubbing a habanero right on your skin where it burns already. It's not too pleasant at first. And then there's also physical therapy, and then TENS units. And if they work, great, but unfortunately there's a lot of, oh, here we go. But unfortunately, a lot of these still have a lot of drawbacks, and there's a lot of holes in the armor still for treatment wise. And then the other option that we have is spinal cord stimulation. Now, a spinal cord stimulator, as you can see on the slide, it gives little pulses to your actual spinal cord. It's a little device that gives electric signals and actually blocks pain signals. Think of it as the wiring system of your body. It just blocks the little signals saying that, like, hey, I'm in a lot of pain. Because what happens is that, if you want to think about it this way, those nerves are short circuiting and causing a lot of pain and discomfort. So we kind of go in there and block it with this system. Now, this is kind of a game changer right now. there's been lots of studies that show that this has been really doing, really being successful with chronic pain. I mean, and this has been around for a while too. I mean, it's been over 30 years. It started in 1989. And people are actually getting at least 50% of pain relief. And I can't tell you, I mean, how many people with chronic pain would love to say, hey, if you could bring that down 50%, that's life-changing. All right, and then here's a little bit more about talking about the benefits. First up, you're not going to be on pain medication. So you're not going to have to worry about addiction. You're not going to have to worry about having drugs that people might be wanting to get from you. You're not going to have some of the bad side effects like drowsiness, not being able to drive, because sometimes if you take your pain medication and you drive and something happens, you're liable for that. And it says here, constipation. And yeah, I mean, we think of it as a joke, but that causes issues for sure. And what's good about this system too, that we're going to be talking about, is that this one actually has a temporary trial portion of it. So if it doesn't work for you, it's not permanent. And here are the numbers that I absolutely love to see. So the blue, the light blue are the people who have actually gotten the spine stimulators. Now, this is showing the people who had at least 50% pain relief. So 50% or greater pain relief with that. We're getting 85% people at 6 months who have had pain relief. That's a huge number. And then a year later, that actually goes up to 86%. Those are fantastic numbers. And then it's also long-term as well. Like these are huge studies that people were doing. And these aren't like old studies either. This was a study from 2001. So this is just last year, like from November, actually. So this is literally a year ago. And here's the nitty-gritty of everything. You get major pain relief with this. 86% of people enjoying long-term pain relief. You get your sleep, and people who don't get sleep, that's worth its weight in gold to be able to sleep soundly through the night. People get better feeling to their feet, so they feel like they're more secure. They'll be able to walk more, feel like they're more stable, and people are happy with this treatment too. I mean, that's always what we go for. We always want people to be happy with what they do with this. All right. So, who's a good candidate for this? First up, diabetes, and then people with painful diabetic neuropathy. So, of course, if you're just diabetic, you don't need to have this right now. But if you're getting pain with this, that's something that might be raising a little bit of a red flag. Like, ooh, what do we need to do to fix this? Of course, we still try to do the pain, the medications. Not the opiates or anything like that, but more the gabapentin, the topicals. Try that stuff first, and sugar control. Like I said, major thing to need to be able to do that. But if we're able to get those, then we do that. But like I said, there's a high failure rate with all of those. So if you're having a lot of pain and you want to just be like, no, I don't want opiates. I don't want anything that's going to be interfering with my life, or else what's the point of this all? So to avoid the side effects, and you can see with the pictures here that like, oh yeah, I'm having a little pain. My favorite picture is actually the middle one with like all the pins. That's pretty accurate from how this is typically described. Stepping on a bunch of thumbtacks. Ow. All right, and then here is also what comes with the system. So first up, so right in the upper corner for trial battery. So what happens, and Dr. Nasser will explain more with this, but we put leads up the back. Dr. Nasser will do that. And then he gives you a little trial battery. See if this works. See if this is going to be helpful for this. And if it is, then we actually put in the permanent leads and the battery. And then the charger will actually, it's very sci-fi, very cool as far as I'm concerned. I'm a big sci-fi nerd. So this is very like cyborg type stuff. But yeah, so the charger actually goes over your skin to charge the battery. And then the remote control, Dr. Nasser will talk a little bit more, but you can actually control how much relief you get with this. And then, all right, and then what to expect with this process. All right, so what happens is that you come in, you see me saying, Doc, I got all this pain. None of this is working. Well, I say, okay, well, we'll get some studies done. We'll get maybe a nerve conduction study. And then I'm going to have you speak with Dr. Nasser. He goes in, talks with you, says, we'll further evaluate, see if you're able to do all this stuff. And if you can, he'll get you scheduled up for this procedure. We do the trial, see if that works. If it does, fantastic. If not, hey, it's a trial. No harm, no foul. And then if you feel like this is, then you proceed with the implant. All right, and then we have a little video for you. So enjoy. There we go.
My name is Mindy, and I live in California. I am a mother, a wife, and a grandmother. My mom used to say, you're eventually going to have diabetes because it's in your family. I've had diabetic neuropathy for probably about 15 years. I didn't understand why my feet tingled and burned, and they were always cold. And when I went to see my doctor, he said, you have what they call diabetic neuropathy. The pain would start from my back down to my hips, and then it just radiate down to my legs, my feet, my toes. I couldn't feel my feet underneath me. They were just cold all the time. I have broke my right ankle 4 different times. The pain impacted my life because I wasn't able to go out and do things with my boys when they were growing up like other moms and dads did. My family members would invite us to things, and I would be like, I just can't, because my feet are hurting really bad. My diabetic neuropathy impacted my sleep because I wasn't sleeping but maybe 2 to 3 hours a night. It would feel like I had knives scratching and digging into my feet all the time. I was just physically in so much pain that I couldn't stand to have my husband hug me, touch me, nothing. I thought, this is the end of my world. I'm going to die young. I'm going to not be here to watch my boys grow up, never see grandbabies. You just feel like there's no hope. After my HFX implant was put in, I felt almost immediate relief. I kind of describe neuropathy in your feet like 1,000 flies and just buzzing. I didn't have that anymore. All the pain was gone. I can finally sleep at least a good 8 hours. I don't feel tired when I wake up in the morning. I feel like I'm ready to jump out of bed and take on the day. The HFX device fits into my daily life because it helps me to get up and do things, not have to worry about having all this pain at the end of the day like I used to have. My medication list that I had before was extremely long. Now I don't take anything for pain at all. It's been a whole different ballgame. I am able to do more things now that the pain prevented me from doing before. I'm able to enjoy cooking a meal for my husband, and I can do things with my granddaughter and my kids. I think they're a whole lot happier now with the mom they have. And that's what I enjoy about my life is I have no more pain. I don't have to depend on anybody else. I can finally start depending on myself. HFX is my best friend.
All right. Okay, so I mean, great testimonial, no question about that. So we're wrapping up my portion a little bit. So in conclusion, so painful diabetic neuropathy, it affects a large portion of the population. And the HFX is actually the only FDA-approved treatment for this. It offers significant relief, and it can help a lot with pain that is just not being responsive. So what we'll have, so if you are interested in this, come in, we'll talk, we'll go over everything, and then we'll get me and Dr. Nasser will evaluate you and go from there. All right. So I'm gonna get ready to turn this over to Dr. Nasser. I'll be around for questions regarding anything for me. But other than that, you guys have a great rest of your night. You're gonna introduce me?
Hello, everybody. I think I have some repeat people here from when we've talked before. I'm going to discuss generalized pain management and back pain and a few things, and then we'll get into some of the modalities that we do and try to focus a little attention on spinal cord stimulation, which I think is a big thing that we want to talk about, especially Dr. Hopkins was mentioning it with diabetic neuropathy and foot pain, et cetera. So starting in here, we're gonna talk about chronic pain treatment options and what might work best for different types of pain, and then maybe some things that you can consider when you go to your next appointment with your doctor. So we want to really understand how pain management doctors or medical providers make a diagnosis and go over some of the basic treatment options. And we'll talk about the advanced interventional treatment that we're doing here at AVORS. And then at the end, we can open up an opportunity for some questions. So symptoms can occur, with or without triggering when you have pain originating from the spine. Usually people can have numbness, pins and needles, tingling, shooting or burning or stabbing pain. It's important to understand that the nerve is the conduit for information. It's how information is transmitted from your body to your brain. So the nerve is how, if you were to touch a fire with your hand, you get a signal to your brain that it's actually hot and to move your hand. So when you have neuropathy or an injury to a nerve or a nerve disease of any type, whether it be a pinched nerve in the spine or damage to the nerves in the feet, that communication between your skin and what you're perceiving to your brain is negative or is affected in an abnormal way. So where right now I'm sitting here and I can just feel my feet are normal, if that communication was affected by nerve damage, I could feel water on my feet, which isn't really there, obviously, or burning or tingling, or even just dull or achy pain. So the communication of the sensation in your skin and in your feet and the tissues as it comes back to your brain is of something abnormal because of the damage to the nerve. So obviously your feet are not wet or your feet are not on fire, but that's how you perceive it. And that's where we come up with this symptom list here as far as the numbness, tingling, and shooting and burning. Weakness is when the nerve becomes more severely damaged, then the actual strength of your leg or your back becomes affected because the nerve has become more progressively damaged. So people who have diabetic neuropathy, for example, it could start with some burning or tingling in the feet and later progress to actual weakness and where the muscles begin to atrophy away, and that's much more severe. And so that's where this list comes from. And so that's neuropathic pain. Mechanical pain is more pain that's in the actual muscles and bones. And we call it mechanical because it's worse with movement, or it's in structures that are affected by movement. So that thus it being mechanical pain. And so you may want to ask yourself, did you feel pain shooting down the back of your legs? Was it severe? Did it affect you being able to walk? Have you tried medication? You can see some of the questions on the screen now. Where is the pain? These are the questions you want to ask yourself or kind of go over with your physician or medical provider when you go see them to discuss the pain. And these are particularly important because the way that we answer these questions is how we make a diagnosis. And, further, does the pain affect your basic ability to do things around the house, be sexually active, do gardening, to be productive in the work environment, or things like that? And so we focus on, everybody says, well, 1 to 10, what's your pain? Is 10 being the worst and 1 or 0 being the least? That's important to me. But what's more important to me when a patient comes in is, can you do your activities of daily living? What types of things is the pain preventing you from doing? Because, we want to treat the pain, but at the end of the day, if we treat the pain and lower the numerical score, but you're not able to get back to living the way you want to live, then, we haven't done things properly. And not necessarily done properly, but we haven't done things to the point to where they're as effective as we'd like them to be. At the end of the day, we want to help people get back to living a quality life, not just reducing the pain score. So, again, people talk about wear and tear or things like that. When we talk about wear and tear or things like that, it's not necessarily usually nerve pain. That's more arthritic pain. I heard it described once like the cartilage in between the joints, especially those in your spine and your hips and knees, is kind of like the tires on a car. And once it wears down, the car's just not going to drive right until it gets addressed. And with that wear of the cartilage from arthritis, we get swelling and inflammation of the joints that become more problematic. And it's so common right now. It's affecting over 14 million Americans. We also know that it's more common in people who are over 60. And I had mentioned this in one of my other talks, and that the number one reason people go to see their doctor in the United States is the common cold. The number two reason is back pain. So that'll tell you right there, the impact of spinal stenosis and back pain on people. And so what is spinal stenosis? It's one of the things that causes back pain. I'm not sure if you can see my cursor on the screen here, but this is where the nerves come out. These are called the foramen. And you can see, obviously, this one is closed and it's pinching the nerve, which makes it red and inflamed. These joints here in the back of the spine are called the facet joints, and those can become arthritic and painful. These are your discs here. And those discs can become swollen or degenerated or bulge back and touch the nerves. And this is obviously the nerve trunk that's coming down and communicates information from all of these potentially damaged structures that goes back into the brain. If you look on it, what's called an axial view, where we look up and down or slice in half, we could see here, this is what stenosis looks like. These are this red line here are the pinched nerves. This is the arthritic joint right here. And this is normal. And you can see the joint's nice and smooth. There's no arthritis. There's no bumps. The nerve has plenty of room to move within the foramen. When we do an epidural injection, we put a needle right in here next to the nerve. When we do a facet injection, we put a needle right in here next to in between these two joints to address the joint pain. This big round white circle is the disc. Anyways, moving on, I accidentally clicked the next slide. How we make a diagnosis. And we make a diagnosis by asking all the questions that we asked earlier. That is the history. So if a patient comes in and says, I had trauma, well, then I'm going to look for something traumatic. If the patient says, I've been doing just fine and this gradually came on over time, I'm going to look for something else. So the most important thing to me and the most important thing to a medical provider when they're treating back pain is what the patient tells them. That's the most important thing. So getting a good history and having a good conversation where you're explaining all of the details of your pain to your doctor is one of the best ways to get to the bottom of things. We can't really treat things well unless we have a good diagnosis. The next part of that is the physical exam. Following that is imaging, the brain MRI, MRI, x-rays, or et cetera, with other type of testing. And occasionally we will use how a patient responds to therapy or an injection to help us finalize or aid in a diagnosis. A diagnosis can be very complicated. Patient can have more than one thing going on. In the previous slide, we just saw the spine. We looked at arthritis, but we also looked at pinched nerves. And we have plenty of patients where we'll address one type of pathology. So we'll address the arthritis, and then they'll have another problem come up after that or in conjunction with that, and it's a separate diagnosis. It's very, very different in treating spine pain and nerve pain because there can be more than one thing contributing to it rather. And we can go in and we'll treat the pain and we'll take care of this particular problem. And when the patient still has pain, but it's of a different type. And so sometimes it's more of just, let's just check these things off the list. Let's get rid of the worst type of pain first and then go to the next type. So once we have a diagnosis, what do we do? How do we treat it? There's a whole bunch of things that we do to treat it. I have them listed here on the screen. And it's important that we embrace what we would call a broad spectrum of treatment options. Most people do not get better from one thing. Most people do not get better just because I gave them a brace, or just because they had physical therapy, or just because we gave them a surgery or an implant. Most people will require a whole host or a complex of things to really address the pain, address the things that have affected their daily living. So I have listed here what I like to give all my patients is therapy. We address and physical and occupational therapy. We look at bracing. We look at medications. Complementary alternative treatment includes massage, acupuncture, chiropractic treatment. I like to look at nutrition as well. I like to look at non-surgical interventions like injections and things like that. And then lastly, I look at surgical treatment and options. And then most importantly is education. You know, I think it's important patients know what they're doing and why they're doing it. You know, sometimes just to be able to explain it to family members or other medical providers when they're asked about it. But for the most part, you know, science shows that when we know why we're doing things, we tend to respond to them better. I'm a real big advocate of patients having buy-in and being on the same page. If a patient doesn't understand what's happening or what's being done for them, then they tend to be less accepting. When we're on the same page and a patient believes in it and buys into it and goes with and really wants to go with the plan, then I have a higher likelihood of getting a better effect of our treatment plan. So education is really important. With physical and occupational therapy, you know, there's some studies that show that yoga is extremely effective if you can't make it to physical or occupational therapy. A home exercise program is very important, even if it's just a light walking program, a treadmill, stretching, but continuing to improve the movement of the tissues and work on exercise is incredibly important. So when you talk to your medical provider, make sure you get an exercise prescription and they tell you what they want you to do and how often they want you to do and what the objectives and goals of doing that exercise is for. And you want to make sure there's proper rationale for it. You know, I have patients who have come to me with carpal tunnel syndrome, and I've sent them for exercise, and they told me I went to physical therapy and they had me riding a bicycle for 30 minutes. Well, clearly riding a bicycle is not the type of exercise for carpal tunnel syndrome. So we want to make sure that the type of exercises that we're doing, the type of therapy that we're getting is very specific to the diagnosis and to what we want to be done. So a therapy prescription should never say evaluate and treat. It should say specific exercises for what your problem is. And the bracing is the same. It's not for everybody. And patients should receive proper instructions on how to use a brace, and the effectiveness of that brace should be monitored from visit to visit. Medications, there's a whole host of million different type of medications we use. Most people just, you know, think that we prescribe primarily painkillers, but which are, you know, termed opioids. But we do a lot of different medications. Sometimes we use what's called adjuvant medications like Lyrica or Neurontin or Cymbalta. Obviously, we do use some painkillers, some opioids, but we also use muscle relaxers and anti-inflammatory medications. The biggest thing in the literature now is that it's suggested by the CDC that we take what's called multimodal approach. And that means we use medications that work in different areas of the brain and have different types of effects to cumulatively come together and treat the pain. We're obviously in a culture now where we're getting away from strong painkillers, and in our practice, we agree with that culture. We try to come away from those painkillers or reduce them whenever possible. That's a big purpose behind the modalities, the therapy, the bracing, is to not necessarily have to use so many strong pain medications, because they are very hard on your body and they're very hard on your nervous system, and oftentimes they can be very addicting. So at the bottom here, I have the word rationale. That's an important word. You know, we want to use a good rationale when we're choosing medications. We want to know what the medications do, why we're using them, and how long we need to be on them. And if we can come off of those medications sooner, then that's going to be quite a bit better. Obviously, there are a large number of patients that have, you know, very difficult disease to deal with, and they have to be on medications long-term, some of them even lifelong, but that's not necessarily everyone, and that should not be the mainstay of any practice. Let's see. So complementary alternative treatment, I mentioned briefly earlier, there are so many different things, and they have all shown to be effective. I would not discount any of these things. These things are very, very good, and it should be part of any comprehensive program. Acupuncture, meditation, chiropractic treatment, biofeedback, hypnosis has been incredibly effective. There's an app you can get for your phone called Pain Pal that helps with hypnosis for pain. Faith healing is effective, psychotherapy, and support and counseling. Some of these things are, you know, you can get for free online. Some of them, you know, you have to go and pay for. Either way, if you're a patient who's having pain, I would definitely think about all of these things and think about how you can employ or utilize them in your pain program. Again, they should not be disregarded. They're very, very effective. In this country, in this part of the world, we tend to lean very heavily on surgery and medications. And in other parts of the world, they're not so heavy on those things, and they tend to use some of these other modalities. I'm a believer in taking a comprehensive approach and really using these things to aid in what we're doing to treat pain. Nutrition is can't be, you know, spoken about enough. That if you're seeing this screen, that gigantic juicy cheeseburger looks absolutely fantastic right now. I'd love to get one for myself. But I know, and this is the God honest truth, if I eat that cheeseburger, I will have a pain in my back. I'm a sufferer of back pain. I've had epidural injections, I've had therapies, all these things that I do for my patients, I've had myself. And I try to eat a semi-anti-inflammatory diet. I'm not as disciplined as I should be, but I can tell you that when I do eat things like a cheeseburger that's on the screen like that, I'll feel pain later that day or the next day. Foods will create an inflammation in your body. The most common foods that create inflammation are dairy, flour, and sugar. And those all sound delicious. One of my favorite things is ice cream, and all of those things, are pretty much in ice cream. But we need to stay away from them if we want to treat the inflammatory problems in our body. We do know that eating a diet that is involving, lean meats and low starches and fruits and vegetables, staying away from high flour products, staying away from high sugary products, eating a right amount of calories. We know that all of those things are very, very good for inflammation. Some people are advocates of the paleo diet. Certainly the cleanest diet a person can eat is a vegan diet. However, even some vegan diets do include too high carbohydrates or other elements that can create inflammation. So if you come to see me, I can get into some more detail of this with you. But if you want to look online, you can look up anti-inflammatory diet or anti-inflammatory foods. But combining proper caloric intake for your body size with the proper food products and taking supplements like turmeric or making sure that your mineral levels are good, things like that, curcumin, these things are all very, very good for inflammation and very, very good to help aid in your pain management program. And then any nutritional program should be goal oriented. There are plenty of nutritional, healthy foods that help with inflammation that are absolutely delicious. But, our marketing and our culture sells us pizza and cheeseburgers and ice cream because those things are all like comfort foods. Comfort foods will not help you with your inflammation or your pain. But you can eat plenty of turkey on Thanksgiving. There's no problem with turkey and a few other things, but definitely want to pay attention to nutrition. Non-surgical interventions, they're all listed there. Mostly we're all talking about injections. Radiofrequency ablation is very popular nowadays. This is where we heat up and ablate the nerves that go to a joint or a particular body part to alleviate pain on a more long-term basis. That's a little bit of a complicated procedure. And if you're going to have that done, you want to make sure you discuss the details of it with your medical provider. But otherwise, we do quite a few of these above mentioned, these injections here on the screen, and they help quite a bit. Sometimes we inject with steroids or without, but it just depends on, what the patient's needs are. The more aggressive treatments are listed here. We do the four main more aggressive treatments that we do in our practice. We do spinal cord stimulators. We do pain medication pumps, Vertiflex implants for foraminal stenosis, and a procedure called mild, which is a decompression of the lumbar spine, removing thickened ligaments, could be pressing on nerves. I'm going to get into a little detail on these procedures now as we move forward in the talk, beginning with spinal cord stimulation. If you remember earlier, I spoke about how there's a communication breakdown when you have nerve problems in your body, and how the tissues communicate back to the brain. The nerves are affected and not communicating well to the brain. So, again, your foot might be looking normal, but the communication to your brain is that it's on fire, or it's wet, or it's having pain. With spinal cord stimulation, this is really a fantastic treatment option for people, because we interrupt that signal and basically correct the signal, change the signal that's coming to your brain to no longer perceive the burning or the water or the tingling or the pain that's in the limb from the nerve damage. And so it's an implanted neuromodulator that we put into the spine. As you can see on the screen here, the device goes, the wires go into the spine, and they're connected to a little generator, and it disrupts or changes the pain signals coming between the spinal cord and the extremities in the brain. There's some more details here on the right side of the screen about really how we define it medically. It's non-pharmacologic treatment, and it delivers a small electrical pulse over the spinal cord. And there's some scientific numbers over there between 2 and 1200 hertz. has been safely determined to be utilized over 40 years, primarily to treat leg pain, but we do this a lot for back pain and hip and knee pain as well. It says here success is defined as achieving 50% pain relief. I don't have anybody that gets 50%. Our patients that we do this for, it's 80, 90% relief, and those are the ones who are going to implant. So, if we see 50%, I mean, I don't see that often. We see quite a bit more. I'm glad that the success level is measured as low, but in all reality, we see, in what we're doing, we see quite a bit. And this was something that we've been doing in our practice for, about 20 years almost. And we've seen recently in 2015, just about, 5-6 years ago, that now they're doing higher frequency, over 10,000 hertz, and it's been incredibly effective. I can tell you that I was doing spinal cord stimulators before that change in the industry, and the change afterwards has been dramatic. Patients have really been happier with the high frequency stimulation. And so, there's we were doing this a lot for back pain and leg pain, for what we call radiculopathy or irritated nerves. And more recently, we can see here that the HFX system has been approved by the FDA for PDN is peripheral neuropathy, peripheral diabetic neuropathy. So we were doing this before it was approved, and a lot of patients were very happy. And as you can see here in the trials, we see that 80% of the people are getting that 50% or greater relief for about a year. I could tell you in our practice, the numbers are quite a bit better. I'd say 80 to 90% of the patients that we present with a spinal cord stimulator trial show 80 to 90% of relief from the trial. People are doing that well. We have a handful of people who are getting maybe 70% or not getting relief, but the numbers are much better than the data shows for the nation in our practice. And I don't think that's necessarily to suggest our practice is just, some spectacular thing that we have some sort of miracle technique. I just think that these are conservative results that you're looking at, and the reality is much better. So that's what I would say. And then also with the higher frequency, previously when we were doing this, we'd have people who are still getting tingling or abnormal feelings from the stimulator. We're seeing pain relief without those things nowadays. So the newer technology, the higher frequency, these things are a lot better. They're MRI safe. They can be used 24 hours a day. Patients get a controller they're very happy with, and they can sleep with it. They can drive with it. They can do everything. So this has been very, very great addition for our practice. I've been happy with it because I get a handful of patients, not a handful, but I get a number of patients where you run out of things to do and you're having trouble treating them. And this helps us to take it to the next level and do something special for them. And so who benefits from this? People have had back surgery and they're continuing to have pain, neuropathic pain, obviously, that we discussed before, from any type of neuropathy. It doesn't have to be diabetic peripheral neuropathy. I have patients who were in a war and were exposed to Agent Orange and they have neuropathy. I have patients who had chemotherapy after cancer. They developed neuropathy from that or radiation, a few different things. And we've put spinal cord stimulators in them and they've been incredibly happy. They've done very, very well with them. And, this is obviously an aggressive surgical invasive procedure. So, we usually will try physical therapy and epidural injections and things like that first, and people still have pain. We have a large number of trauma patients who've had crushed limbs and have resultant chronic regional pain syndrome, or RSD, that have responded incredibly well to spinal cord stimulation. And so the other thing too, how I like to use spinal cord stimulation in a big way in my practice is patients who have back pain. It's been pretty well controlled with medications. And we say, hey, listen, you know what? I'd like to see you on fewer medications or less medication. Let's try this surgical modality. If it helps you, we can reduce your pain medication. And I could tell you, as a doctor, especially a pain specialist for almost 20 years now, I would rather see somebody who had a procedure like this and did not need to take oral opioids or painkillers, because those things are, again, very hard on your body, can be very harmful, can be very addicting. In my opinion, something like this is safer than being on pain medication for the rest of your life, or even for a large number of years. And so again, this is another slide displaying, some of the things that we've seen with the HFX stimulator, that it's very significant relief for back and leg pain. Obviously doesn't involve anything, like addicting pain medicines that we're trying to get people off of nowadays. And it gives us the widest range of frequencies and waveforms to address different types of pain, gives us that high frequency treatment. Again, here's some more numbers supporting that, showing what we do and how and what the results have been with regards to implanting this device and treating people with it. I like this here. 80% of the patients receive long-term relief. That means 8 out of 10 patients that I give one of these implants to is feeling better at a year or further out. And that speaks a lot to me. 73% have improved. So 3 out of 4 patients have an improvement in function, meaning those patients can sleep better, cut their grass better, clean their home better, spend time with their children or grandchildren better. That's an improvement in function, take care of themselves better, etc. The other device that we use often is an intrathecal pain pump. These are also very, very effective. We put medicine inside the mechanical pump, and the pump catheter goes in a similar position to where the stimulator leads go into the spine, but this is going into the spinal fluid where the nerves are. And we adjust it. We fill the pump with pain medication. And so if a patient is on, let's say the patient is taking oral morphine and we want to switch that over, we can take that same medication and put it into the pump and treat them in that way. This is great for back pain, leg pain, hip pain, arthritis. It's also great for neuropathy. We use some other medications besides morphine that treat nerve pain into the pump. The pump works in an absolutely fantastic way. I often tell my patients I can program the pump to do anything your alarm clock can do. If we need a dose of medication every hour, every 30 minutes, if we need to give medication around the clock to treat your pain, the pumps are very effective. The pump is also a good alternative sometimes to a stimulator. I have some patients where the anatomy doesn't allow us to put in a stimulator because the space is too small in the spine. And I have a couple of patients even just this week where we're going to switch them. We were going to plan for a stimulator, but instead we're planning for a pain pump because there was no room for the stimulator because of they have some scar tissue from previous surgery or things like that. The pain pump usually gets filled with medication about every 3 months. We do regular ongoing programming to address patients' pain. The nice thing about the programming that we do that I think is unique to our practice is I often tell people it takes at least 2 to 3 months after getting your implant before we can really dial the pump in, because I like patients to come in and tell me, I'll say, when are you having the pain? How much pain are you having? What are you doing? And some people say, well, doctor, in the morning, I like to get up and I cook breakfast for my family or I clean my house, and that's when I have the most pain. And so then I'll go to the pain pump and I'll say, what time is that? Well, they say, oh, that's at 7:30, doctor. Then I go and I can program at 7:30 a.m. to give the patient an additional dose from that pain pump to allow them to do that activity that day. So these are very good. They're MRI safe. These and the stimulators both usually need to be replaced about every 7 years, and patients have been very, very happy with them. We do quite a number of these devices, and these devices are, both the stimulator and the pump are things that patients come in and tell me, rarely do I hear this particular term, but they say, this device changed my life. And I do hear that from these two things. So I did have, let me just go back one slide. There we go. Previous. So this is just the two different illustration of what the two different things do. If you look on the left side of the screen, you can see that pump is delivering medicine, and you can see the different color. It's like a light blue gray. That's where the medication is going over the spinal nerves that's coming out of the pump right here. On the right side of the screen, you can see a stimulator. Stimulator is a bit smaller. The generator is about half the size as the pump. And you can see the wires going into the spine, and those wires are sending an electrical signal doing, as we spoke about earlier. So, the next device is something called Vertiflex. Vertiflex is for when we looked at those pictures earlier, and you can see if this is you where walking causing a sharp shooting pain down your leg, you need to bend forward or sit forward in a chair and lean onto the shopping cart. That could be from those pinched nerves in your back. Often these patients who benefit from Vertiflex are patients who, I do a simple test in the office. I bend backwards. Does that cause pain to shoot into your buttocks or legs? And then if you bend forward and it gets better, then you would benefit from Vertiflex. If you look here, you can see this is the Vertiflex device. So when a patient were to bend backwards, it would pinch these nerves. Bending forward would open this hole where the nerve is. We put this device in, it keeps that hole open, and it reduces the amount of pain that a patient would have afterward. This is how the procedure is performed. And this is about 10 to 15 minutes of surgery. You get one stitch in your back, It's very, very simple, very, very easy, and patients tend to do extremely well with this, especially for what we would have for sciatic or radicular pain that is worse with bending backwards. This is again a different procedure called mild. We just started doing this procedure this year. It's been around for many, many years. We had some questions about it. We weren't sure. We looked up the results. It's been absolutely fantastic. This is also a procedure where patients say, hey, this impacted my life in a really, really positive way. I'm able to do so much more. So if you go back, let me just go back one slide. And although this is a Vertiflex slide, I'm going to use it to discuss the mild procedure. And if you're looking at this nerve here, what we're not seeing in the picture are ligaments. And there is a ligament that goes right here. And if you would imagine a thick ligament right there pinching the nerve, that's called your ligamentum flavum. So when you have spinal stenosis, there's different types of stenosis. This is the foramen where the nerve comes out. And when that's pinched because of a herniated disc, that would be called foraminal stenosis. And for foraminal stenosis, we often use this device here, the Vertiflex, to open that hole. When you have stenosis in the very, clicking too much. Let me go back to that again. When you have stenosis from a thickened ligament back here, or from a herniated disc that's in that little space there, that would be called central stenosis. And central stenosis also pinches the nerves and irritates them. When we do a mild procedure, mild stands for minimally invasive lumbar decompression. We take a little instrument and we put it right in here. The instrument's about as big as a pen. And we can cut a little piece of that ligament out that's been pressing on the nerve, and we pull it out. The nice thing about the mild procedure is, again, it only requires one little stitch. The incision is less than a half an inch. It's more of a puncture than it is an incision. There are no implants, and patients walk right out of the operating room. It's about a 10-minute surgery, and they feel very, very good, and they feel quite a bit better. And so we like the mild procedure a lot. It helps a lot when a person has central canal stenosis and pinched nerves and irritation. Most of the time when people go for a mild procedure, they'll tell me, hey, my legs feel heavy. There's sharp shooting pain in my legs. And I look on an MRI and I can see that the ligament is there thickened and pinching the nerve. And it gives them, quite a bit of relief. So what are we looking for? We're trying to get people back to dancing, shopping, gardening, grandkids, hiking, all of these wonderful things. We're trying to get people back to living their life. We are actively looking for new opportunities to learn and grow and do what we're doing every day. I've been doing this for almost 20 years now. And I can tell you that when I started doing it, we weren't doing any of the 4 things that I listed as our aggressive modalities: the stimulator, the mild, the Vertiflex, or the pumps. And as we've grown in the practice and we've learned more and really pursued helping people as much as we can, we've been adding these things. I hope to add even more things in the coming years to our practice, because no 2 patients are the same and no one modality fixes everybody. And you have to look at a patient individually and say, well, what can I do to really help a person? What's available to me? At the end of the day, there are many patients who require more than one of these things. I have patients in my practice that have a Vertiflex, they've had a mild, and they have a stimulator. I have patients in my practice that have a stimulator and a pain pump. I have patients in my practice that have had a mild and a stimulator, and any other combination you can think of. And each time we have to go back to the drawing board and reassess each patient and see what they're having problems with. Again, sometimes I can get lucky and I'll get rid of back pain and leg pain with a stimulator. Sometimes I don't, and I just get rid of the leg pain, and I got to go back and look at a patient's back and see what's going on. There are plenty of times when patients come in with back pain and leg pain, and we address one part of it with one modality or one thing, and we got to go back and look at doing something else. So it's not like, oh, I have knee pain, I'm going to get a knee replacement, it's going to fix everything. I think we know better now. Here we are, almost 2023, and we know better in medicine that each patient is very, very complicated and may have different levels of things going on. This is just more discussion here. I give you a few minutes if you want to look at this slide about the different things that we do with spinal cord stimulation and why we use different frequencies and how effective they are, and potential adverse effects. Obviously, when you go over anything with your medical provider, especially if they're recommending a surgery or any type of interventional procedure, you want to discuss the risks, the benefits, the potential complications, and just say, listen, doctor, if something goes wrong, what could happen to me? And you want to make sure you go over those things, and then ask the doctor, how many times have you seen that? Here it lists burns or different things like that, or et cetera, et cetera. we've never seen any of those things. They're extremely rare. Abnormal sensation and stimulation, those things are very rare. Oftentimes those are related to, improper or placement of the leads or migration of the leads. Anybody who's doing these should know the risks, benefits, and alternatives, and should be able to discuss them with you in detail. Obviously, if you come see me, I'm happy to talk about, all of that with you. Not common complications, but complications of surgery it can be a variety of things. I would say probably the most common thing that we try to avoid is infection or nerve damage. We have had to take some of these devices out when they were ineffective or had complications, but that's to be expected with any type of surgical procedure. We're not dealing with medicine is not an exact science, and no two situations are the same, and complications do arise, but how we handle those complications is the most appropriate thing. So you want to make sure that you have a medical provider that's very attentive, very available, and God forbid something were to go wrong, they're available. They can help you get through it. At that, I will leave it open to any questions. Do we have a moderator handling questions? Okay.
Yes. Thank you so much, Dr. Nasser and Dr. Hopkins, for this beneficial information. At this point, we'll open it up for Q&A. I will go ahead and start by reading the questions I've received so far. As a reminder, if you'd like to ask something and haven't submitted already, feel free to do so by submitting your question via the chat function. So our first question is the pain pump completely internal or is it part exposed?
It's completely implanted. Everything's inside.
Okay. And we actually do not have any other questions at this time.
Okay. I can hang out for a few more minutes if they want to. Maybe people will chime in.
Yeah.
Did I miss anything?
Nope. Those are all the questions right now. You can always send in your questions to the texting function. And I'd really like to thank you, Dr. Nasser and Dr. Hopkins, for providing such important and helpful information to your patients. And we appreciate you making yourself available today. Do you have any other closing comments or statements?
I do not.
I just want to thank everybody for coming on in and listening to us. Hopefully we answered some questions, and hopefully we made a path where you guys can get some help.
I agree.
Okay. There's another question. If a patient receives a few MRI and CT scans, can they still get a pain pump?
Absolutely. Yeah, pain pumps, just like the stimulators, are MRI safe.
Okay, there's a patient here that wants to make an appointment to talk about getting the stimulator.
Okay. 661-726-5005.
Okay, I call the office and make an appointment, and I will facilitate as well.
Perfect.
All right, and there's a comment here. Thank you for a great presentation.
Oh, thank you very much.
Thank you very much. Our pleasure.
Okay, well, that is all, and this concludes our educational seminar. Thank you again, everyone, and have a great rest of your evening.
Thank you so much. Take care.
Take
Y'all
care.
have a great one.
Good night.